These autonomic nervous system problems tend to have a very classic presentation. What you need to see is that there is an unknown drug you will have to identify, and here the unknown drug is drug R. This drug will have to be taken out of the list of answers here, and it's always relevant to check your list of answers in board question with ANSProblems. It'll help you narrow down the pharmacology. Look, your choices will be epi, which is alpha-1, beta-1, beta-2 agonist, norepi, which is alpha-1, beta-1 agonist, phenylephrine, which is an alpha-1 agonist, isoproterenol, which is beta-1 and beta-2, and terbutaline, which is beta-2. Notice then that your answers want you to work out alpha and beta receptors. So don't go and bang your head on the wall thinking, oh, maybe it's a muscarinic agonist, or a calcium channel blocker, or God knows what other pharmacology. Only limit yourself to the choices you're going to have to work with. Here, alpha or beta drugs. Fine. Then how is the problem set up? The problem is set up with first one experiment that is called the control. In a control experiment, you have the unknown drug by itself. And here, to start our process of reviewing problems, we decided to work with a tracing because you're already familiar with that process. What would you tell me drug R is doing? Look at before drug R, after drug R. You know, it seems that drug R does one major thing right now, increase blood pressure. And then look at drug R and answer for me, does it change the heart rate? You see the heart rate before, you see the heart rate after. It also increases the heart rate. So this is a drug that increases blood pressure and heart rate and works through alpha or beta receptors. The idea is already just looking at the first two choices, they could be correct. It could have been epinephrine at high dose. I could assume that. Or it could have been norepinephrine. So I cannot distinguish my drug R just based on the tracing and looking at the answers. That's done on purpose. It's done on purpose because what the exam wants you to do is to use then drug R in other experiments, and these are all individual stories, one after the other, showing you your drug R first in presence of phenoxybenzamine, an alpha blocker, then your drug R in presence of mecamylamine, a ganglionic blocker, and then your drug R in presence of propranolol, a beta blocker. Here's the way I want you to always approach those. We're going to write ourselves two big questions. First question you're going to think about is blockers do absolutely nothing. So the only reason a blocker would result in a change in the tracing is that the unknown drug was using the receptor. So your first question you're asking yourself in answering those problems is, does the blocker, and I'm spelling it out with you, does the blocker change drug R's response in any ways? So does the blocker change R in any ways? And basically to do this, you're going to compare with the control. The control tracing being the drug R alone. Look for instance here. Does phenoxybenzamine, the alpha blocker, change drug R's response in any ways? Compare it with the control experiment. Does the tracing look the same or did it change? Notice, in presence of phenoxybenzamine, drug R no longer shows this big increase in blood pressure. Drug R primarily now changes the heart rate. So I still see the increased heart rate, but I no longer see the increase in blood pressure. So the alpha blocker changed my tracing. Look at it in your syllabus, it'll be more obvious than on my slide PowerPoint here. And if that's the case, then as we go back to our diagram, there were two possibilities to answer this question. By looking at the control, it was either yes, there was a change, or no, there was no change. If your answer is yes, the blocker changed something, then it would mean R uses that receptor. The receptor that you blocked is a receptor that is part of drug R's pharmacology. If your answer is no, then it means R does not use this receptor. Let me find you an example where R does not use a receptor that is blocked. If I look back at my PowerPoint slide, tell me about mecamylamine and drug R. Does mecamylamine change drug R's response in any ways? Look at the tracing in the control, look at the tracing with mecamylamine. They are identical. So it tells you drug R never used a ganglionic synapse, a nicotinic neuronal receptor was not involved in drug R's response. You know, it means that then any heart rate changes I'm looking at are not due to reflexes. So your first point is identify if a blocker changes the response or not. Now let me clean this up a little bit, and you've already now established the first question, which is, for instance, in presence of an alpha blocker like phenoxybenzamine, there was a change, therefore R uses alpha 1 receptors to increase blood pressure. Now here's the big story then to finish that analysis. You know that drugs can bind more than one receptors, so you have a second question to ask yourself, which is, in presence of this blocker, can the drug still do some effect? To do this story, you're going to have to compare just in the experiment what happened before drug R and what happened after drug R. Notice R still increases the heart rate. And if drug R still increases the heart rate in presence of an alpha blocker, it has to mean that it uses other receptors than the alpha. Well, let's write this on our sheet then. Ask yourself your second question, which is, in presence of a blocker, for example like phenoxybenzamine, in presence of the blocker, can the drug R still do something? And if it can still do something, then you know alpha blockade did not cancel all of its pharmacology. If the answer is yes, R uses also other receptors. And then you have to find what are the other receptors the drug is binding to for these other effects that are not blocked by your antagonist. If your answer is no, then R only uses the receptors you blocked. So then it would be a drug that really only uses one single receptor. Well, once you have these two questions, and let me show them back to you in case you didn't have time to write them. First question, does the blocker change drug R in any ways? You compare with the control. If your answer is yes, the receptor uses that receptor. If your answer is no, the receptor doesn't use the receptor. Second question, in presence of the blocker, can drug R still do something? If your answer is yes, drug R uses also other receptors besides the one you block. If your answer is no, the only receptor drug R uses is the receptor you blocked in this experiment. To answer this question too, just use the experiment, and what you compare is baseline versus after the drug. So you don't look at the control right there. Well, we can now get to these problems and try and find our answers. You'll often find that your limiting factor initially, if you've understood this, is the name of the drugs and what receptors they bind to. So really, until you're familiar with all the drugs we've seen in that section and what every receptor does, which we reviewed at the beginning of the sections, don't even attempt the problem because you're going to want to commit suicide. And without me telling you what to use to make it a nice forensic case, it's going to be a boring suicide, so you're not allowed to do it. So make sure you review the notes first and then do the problems. Shall we try? Let's try some of them. So just remind me, what did drug R do by itself? In the control panel, it increased blood pressure, it increased heart rate. All your choices were what type of receptors? Alpha or beta agonists. So drugs that stimulate alpha or beta receptors. Let's just quickly remember that an alpha 1 stimulation increases blood pressure, a beta 1 stimulation increases heart rate, a beta 2 stimulation lowers blood pressure. That's as far as it goes. In presence of the alpha blocker phenoxybenzamine, is there a change in drug R's response? Answer is yes, there's a change. There's no more increase in blood pressure. Therefore, the increased blood pressure was due to alpha-1 activity. If it was due to alpha-1 activity, I know drug R is at least an alpha-1 agonist. Does it have other pharmacology? I'm going to look at before drug R, after drug R in this experiment. It still increases heart rate. And what is a receptor you could choose from between alpha or beta to increase the heart rate? I'm hoping you immediately tell me must have beta-1 activity. And importantly, then I'm looking for a drug that is both alpha-1 agonist and beta-1 agonist. Who's your best candidate as an answer? Norepinephrine. Why not epinephrine, you're thinking? Well, with an alpha blocker in presence of a high-dose epi, what should have happened to the blood pressure? You remember it would have unmasked the beta-2 effect, and if it had been epinephrine, this would have gone down. I would have seen hypotension. I see no beta-2 activity for drug R. There is no epinephrine reversal, so it must be norepinephrine. It is not phenylephrine because as an alpha-1 agonist, this is not a drug that causes tachycardia. It is not isoproterenol or terbutaline. These are two drugs that do not increase blood pressure, that decrease it. Notice we answered our problem using a single experiment. This is another point I want you to get for your exam. You do not need to use all the information. It's a little bit like a physiopath question with lab data that would give you all the lab data from clinical chemistry, and all you needed was pH, PCO2, and bicarb to answer your question. We can do the same to you with Pharm, give you plenty more information than you need in order to answer. The point is, you use one of these experiments and you analyze it logically, step by step. Is there a change with the control, yes or no? Is there still some pharmacology in presence of a blocker, yes or no? Look, just for the heck of it, let's try and answer it using the drug propranolol, just to see if we could have done the same job. And you'll see that we can. What is propranolol, by the way? I forgot. Yeah, it's a beta blocker. And what is my first question? Does the beta blocker propranolol change drug R's response in any ways? Does the tracing look different? Of course, it looks different. You see, there's no more tachycardia, so I can say, hey, the increased heart rate was due to a beta receptor, and it had to be due to beta-1 because only beta-1 increases heart rate. How about my second question? In presence of a beta blocker, can drug R still do some pharmacology? Look, before drug R, after drug R. Drug R can still increase blood pressure. So it must be something else besides a beta agonist. What type of receptor to increase blood pressure? Must be alpha-1 agonist. You could have done the same job with propranolol. And if you're not sure, believe it or not, you could have done it with mecamylamine too. The only thing a mecamylamine or hexamethonium-like drug would do is get rid of a baroreceptor reflex. So all you can say with this experiment is the tachycardia drug R was doing, it's not due to a reflex, it's truly a beta-1 effect of the drug. And it's a beta-1 effect for tachycardia to increase blood pressure. It must also be an alpha-1 agonist. You see, you could have used all of these experiments or only one to answer your question. Well, let's try and do a fresh one. Let's do drug U. As a matter of fact, that's exactly what I'm doing, drugging U. As I'm looking at drug U here, what does it do by itself? You see before and after drug U, an increased blood pressure. Is there a change in heart rate? Doesn't look like it, unlike the previous problem. Does phenoxybenzamine, the alpha blocker, change drug U's response in any ways? Is there a change when I contrast with control? You notice the tracing is not the same. Therefore, I know U has alpha-1 agonist activity. Second question. In presence of the alpha blocker, can drug U still do something before and after? There's no more effect of drug U, so there's no more pharmacology besides the alpha-1 stimulation. Drug U is purely an alpha agonist, so what would be your answer? Are you ready for C? Phenylephrine. Methoxamine would have been another potential choice if it was available. These are alpha-1 agonists. By the way, if you wanted to confirm for yourself there was no beta responses, does propranolol change drug use response compared to control? There is absolutely no difference in drug use effect whether a beta blocker is there or not. So you know that U has no beta pharmacology. Well, it means that then within the drugs given, it's purely an alpha agonist. You could have used either experiments to come up to your answer. Let's do another one. And finally, we actually have a print of what's in the book, so you see exactly the same tracing as in the book, which is easier for us to work on, isn't it? So as I'm looking at drug S here, what does it do for a living? It's a drug that increases the heart rate, and be careful, after a short spike, it does drop the blood pressure. I'm still looking at alpha or beta drugs. Does phenoxybenzamine, the alpha blocker, change drug S's response in any ways? I compare to the control, there is no change whatsoever. So S has no alpha-1 activity. The only pharmacology it must have then, it must be a beta agonist. As a matter of fact, double check it for yourself. Does propranolol change drug S's response in any ways? Notice S has no more pharmacology when propranolol is added. S is a beta agonist. And both the tachycardia and the blood pressure drop were due to beta receptors. So how do I explain the tachycardia? Must be beta 1. The hypotension must be beta 2. If you're worried about the tachycardia being a reflex, mecamylamine does not cancel the actual tachycardia. And if mecamylamine does not cancel the tachycardia, it is not a reflex. It's truly the beta 1 effect of the drug. Who can you choose here in your answers as a beta 1, beta 2 agonist? No alpha activity. Your best choice, isoproterenol. Your second best choice would have been epinephrine. But to choose epinephrine, remember, you'd have to assume a low-dose epinephrine. Well, isoproterenol is a better answer. And why is it not terbutaline? I'm hoping you tell me because terbutaline is only beta 2. And if a beta 2 agonist had caused tachycardia, it would have been a reflex tachycardia due to hypotension. And reflexes would have been cancelled by the drug mecamylamine. So no, it's a pure beta 1, beta 2 agonist type of drug. Of course, you can answer phenylephrine or norepinephrine with alpha agonistic activity that would have increased blood pressure, not decreased it. So let's look at drug H. Drug H is like drug R. Drug H is a drug that increases blood pressure and increases the heart rate in the control. Does phenoxybenzamine change drug H's response? It does. So H has alpha-1 activity, has alpha-1 agonist activity to increase blood pressure. Look now, in presence of the alpha blocker, can drug H still do some pharmacology? Yes, H still increases the heart rate, but now also, look at your tracing, decreases blood pressure. Now you've got to be astute with this. Who has a change from hypertension to hypotension in presence of an alpha blocker? You have to know this code now. It has to be epinephrine. Only epinephrine could show that reversal in blood pressure in presence of alpha antagonist. It was the unmasking of the beta 2 effect. So here the phenoxybenzamine is the one that allows you the differentiation between norepi and a high-dose epinephrine. For that matter, contrast drug R. In drug R, in presence of phenoxybenzamine, there was no beta 2 effect. There was no drop in blood pressure. With drug H, you see that reversal in blood pressure. So epinephrine for this one. How about this tracing? In this tracing, I'm looking at drug X, might be ecstasy, who knows. And what it does is lowers blood pressure, and you can see as well as I can here, increases the heart rate. Does phenoxybenzamine change anything? I'm looking at my alpha blocker against the control, no change. So I can say X has no alpha-1 pharmacology, so it must be a beta agonist. As a beta agonist, I confirm propranolol cancel all the effect of drug X, so no doubt X is beta agonist. That is very similar to our drug S, which was isoproterenol. So here what you must be very careful with is look a second at the mecamylamine experiment and tell me, did mecamylamine do anything to drug X? You see what happened? In presence of mecamylamine, there's no more tachycardia, no more increase in heart rate. If there's no more tachycardia, it had to mean that the increased heart rate was due to a reflex. It was not the drug doing it, it was actually the hypotension that did the reflex tachycardia. So how do you cause hypotension with alpha or beta receptors? Well, you want a beta 2 agonist effect to lower blood pressure, and you certainly don't want a beta 1 effect from that drug, because if it had a beta 1 effect, mecamylamine would never have cancelled it. It must be purely a beta 2 agonist. That is why you're going to answer which drug? Terbutaline, the drug for asthma, that is a pure beta 2 agonist, certainly not isoproterenol, which has beta 1 activity, or epinephrine, which has beta 1 when it has beta 2, maybe even alpha 1, or norepi or phenylephrine, which can never lower blood pressure. Well, I hope it helped you for those tracings. Now, after this experiment with tracings, we're going to look at some that have different looks, but still very similar approaches. So once you have done enough, probably you'll be set to really practice some in the Q bank or anywhere else you find some good examples of questions to practice for your test.